Good afternoon, everyone. My name's Melissa Fox. I'm CEO of Health Consumers Queensland, and welcome to our third webinar. We'll just give you a moment to all enter. The numbers are ticking over faster than the rise in Omicron. It's too early to make that joke. Sorry. So we've got quite a few people registered today. Over 250 from right across Queensland and even further. So we'll just wait. We know that not everyone who registers is able to join us, and they'll be able to watch the recording later. Just give it one more minute. Okay, all right, that seems to have slowed down. All right, well, look, thank you, everyone. As I mentioned, my name's Melissa Fox. I'm CEO of Health Consumers Queensland, and I'd like to start by acknowledging the traditional owners of the land on which I am today, the Yagara and the Turrbal people, and pay my respects to elders, past, present, and emerging, and acknowledge that the sovereignty of this land was never ceded. As I said, I would like to thank you for joining us at our third webinar here at Health Consumers Queensland. We are recording this so that we can share it afterwards. So please, if you miss any important points, you can come back. So today's topic is preparing rural and remote communities for COVID. And thank you to those of you who registered questions, documented questions as you registered. We received many, and we've tried to incorporate as many of them as possible into our conversation with today's panellists. If you have further comments or further questions as we go through today's session, please pop them in the chat. Also, introduce yourself in the chat. We love to know who we're speaking to and where you're coming from today. We will try to get to as many of those questions as possible, but given the time constraints, it's probably unlikely we'll get to them all. So we'll share them with Konrad and Emily and anyone else who needs to know them to be able to get those those answers back to the community. We welcome courteous and respectful participation. So we'll be keeping an eye on the conversation in the chat and removing any comments that aren't in line with our social media policy. I think that's about it for housekeeping. Final thing is we will be producing a one-pager of a summary from what we've heard from our three webinars, and key important messages and any outstanding issues, gaps, challenges that you're needing met. So we'll circulate that tomorrow, and we will also put the video up. You can go and watch the videos of the first two sessions as well. They're on our website now, and we'll pop those in the chat. During the pandemic, Health Consumers Queensland, as Queensland's peak health consumer organisation, like it says on the cereal box, has been working to listen to consumers and carers from a diverse range of backgrounds right across Queensland throughout the pandemic. And we've held approximately 50 online consumer conversations throughout on different topics and issues that you've told us are important at each stage of the pandemic. We've been summarising those, putting them into issues papers and circulating them far and wide to decision makers within the health system, amongst consumers who sit on different committees, and to people throughout the system, so that your voices can make a difference. We have, as I said, published videos of some of those. You can see them online. And in the main, who have attended those events have been, as I said, consumers and carers. But for these webcasts, of which this is the third, we really wanted to extend the reach. We're grateful to those of you who have circulated the details. We know we're getting further and wider with each one. We've gone out to neighbourhood centres, to NGOs, and we've got people here today, representatives from Aboriginal, Shire and City Councils, charities and chambers of commerce, so welcome, also from some different parts of government. And we're also aware that we have a large number of people online who work within the health system. So within the department, including the Office of Rural and Remote Health, welcome, HHSs, community-controlled organisations, retrieval services, Queensland Ambulance Service, and professional associations, including the Rural Doctors Association of Queensland and the Australian Medical Association of Queensland. So thank you for joining us. And today we've even got some people from as far as Norfolk Island who will be receiving support from some Queensland Health Services come the new year. So welcome to you as well. So those of you within the health service, you need to be just as prepared as us to know what's to come, to be able to care for us, care for yourselves, care for your families, and for us all to stay safe. And we're especially grateful to those of you who are working harder than ever. You've been working so hard for 2 years and harder than ever as our borders open to look after people with COVID, care as usual, and we know the sacrifice that you and your families have made and are continuing to make so that so many of us can have Christmas with our families. I wanted to say thank you from the bottom of our heart from all the consumers of Queensland. On to our session for today. So we will be speaking to health consumers and we will have this available for them to watch afterwards. And today's special guests, I'm delighted to invite along the co-chairs of Queensland's statewide rural and remote clinical network. So first up, we have Konrad Kangru, who is GP supervisor and medical educator in the Whitsundays. Konrad is a passionate advocate for rural healthcare services, and he is one of the 2 co-chairs of the Rural and Remote Statewide Clinical Network. Dr. Emily Moody is a senior medical officer at Laidley Hospital in the Lockyer Valley and works part-time for ACRM as a medical educator, and that is the Australian College of Rural and Remote Medicine, one of the 2 GP training organisations in Queensland. I think I've got that right. She recently stepped down as acting clinical director for Westmoreton Rural Medicine, which includes Gatton, Boonah, Esk and Laidley hospitals, and she is the other co-chair of the statewide rural and remote clinical network. So throughout the pandemic, we've been hearing the concerns of consumers and health staff in rural and remote areas of Queensland about how a COVID outbreak could affect your communities and your families. There are large sections of Queensland which have been fortunate to not have seen a single case of COVID, but this is fast changing. What does it mean now that COVID is in Queensland and comes into areas that haven't been exposed to it? We're grateful today to be able to share information about how you can protect yourselves and what care might look like when COVID arrives in your communities. But Konrad, first of all, could we start with you explaining what the Rural and Remote Clinical Network is and what its role has been during the pandemic response? And could you start by explaining exactly what we mean when we say rural and remote Queensland and what we don't mean?
Absolutely, Melissa. It's a pleasure to be with all of you today. I'm coming to you from Ngaro territory up in the Whitsundays at Proserpine, where I live and work. And so within Queensland Health, we are very, very fortunate that we have got this network of our statewide clinical networks. In general, they bring together clinicians who have got particular experience in a particular disease area or a group of patients. Statewide Rural and Remote Clinical Network is unique in that we are distributed right across the whole width and breadth of Queensland. So our real core constituency are those communities who we talk about modified Monash model, or Triple M, 4 to 7 communities. We're not talking about the urban areas. But that also means that we have got well over 100 member facilities. All of the little primary health services, the multi-purpose health services, the district hospitals, all of those facilities and all of those clinicians are our members. We're the ones who are the voice for them. And they're small places. They might have small staffs. They might not have strong union delegates, whatever. And so Statewide Rural and Remote Clinical Network is proud to continue to be the voice of these outstanding clinical supports. Now, it's also very difficult for them to be able to contextualise those large messages, those large resource-dependent responses that often we hear out of southeast Queensland into what it actually is in their area. We don't have negative isolation rooms in all of our small towns. Retrieval services are a major issue for us. So we make sure that not only do we bring down the messages from the hierarchy to mean something to our local clinicians, but we also bring their voices up so that the people in Charlotte Street really are aware of how this actually looks when you're talking about Torres and Cape, when you're talking about Central West, when you're talking about the Southern Darling Downs. This isn't just what we're talking about within Brisbane.
That's great. Thanks, Konrad. And I've just noticed in the chat that Carolyn, also from the Upper Lockyer Valley, is with us today. She is the consumer representative that sits on your steering committee. So it's great to have Carolyn here today representing the partnerships that exist between the clinical networks and consumer representatives. Konrad, can I just get you to explain, we have a lot of acronyms and frameworks and structures in health, the Monash 4 to 7, etc., etc. Could you explain what that means?
Yeah, absolutely. So the federal government uses all sorts of different tools to allocate how rural an area is. About 10 years ago, they changed over to this Monash model of rurality. So we talk about capital cities as being a 1. We talk about our urban, suburban areas as being a 2. And then we go into our regional areas as being 3. When you get into 4, you're talking about places like here at Proserpine or Emerald. When you're getting into 5, you're talking, so Proserpine actually is a 5. You're getting into 6, you're going sort of out into the Mount Isa areas and so on and so on. So it's not just about areas being small, but it's about their distance from major services and major areas. So it really is, it's quite a coarse tool, granted, it's not perfect, none of the tools are perfect, but it does definitely mean that resources and efforts which are meant to go into rural areas can be pretty reliably across Australia, not just across Queensland, applied where they belong, not just, marginal seats for MPs who want to access services that otherwise really need to come to rural areas where they belong.
Okay, great, excellent. And I know that we could dive into all the issues to do with rural and remote health, and hopefully one day when we're not so focused on COVID, we'll have the chance to. But the Rural and Remote Clinical Network, what's been your role in the pandemic response and in COVID and the specific planning that you've done?
We were actually really far ahead of the curve. In fact, back in April last year, we were working very closely with our partners in the Respiratory Clinical Network of working out how would actually a COVID response look for our patients and our communities. Now, obviously, that was when we were talking about the original Wuhan or the Alpha variant. Things have changed a lot since then. But making sure that our members and our facilities have got patient flows, how could they implement social distancing, what realistic retrieval access have they got, how would they manage if some of their staff actually were exposed to COVID and had to go off, what additional backups have they got in their local community, what extra resources would they need, all of those multitude of things that small services can't really work through on their own. Sometimes they need that little bit of a big brother or big sister just to help them along, and that's the voice that we try to be.
That's great. Thanks, Konrad. Excellent. So, Emily, what do we know about COVID-19 and now Omicron? And how do the vaccinations work to protect us from serious disease? And what impact does that modelling have for rural and remote communities and what we're facing now?
All right, how much time have we got, Melissa? That's a big question.
2 minutes, go.
Yeah, that's it. And thanks again for having us today. And I'm on Yugara country. So, look, I think we all know now that the coronavirus disease has actually been with us since December 2019. So it's 2 years ago. So it's a newly discovered severe acute respiratory syndrome coronavirus 2, SARS-CoV-2. And it was declared a public health emergency of international concern by the WHO back in the 30th of January 2020. So we know that the majority of people who are affected with the COVID-19 virus experience only mild symptoms and recover without requiring special treatment. But some people will experience moderate or severe disease. And those that are more likely to develop serious disease are those who are elderly or have underlying chronic medical conditions. There are several variants of the SARS-CoV-2 virus, as we've already spoken about a few. So the one that's generating the most interest at the moment is the most newly discovered variant, Omicron, which was discovered in South Africa. So it's a virus that seems to transmit faster than the other variants, but does seem to have a milder disease severity. But I mean, the evidence really still isn't there to talk about the transmissibility, the capacity to cause severe disease, and the overall impact of the Omicron variant. So in Queensland, I just looked it up before this talk. So we've had 86 total new cases today of both Delta and Omicron variants. And we've got 269 active cases in total. And Omicron is actually now the dominant variant of the virus in Queensland. There's twice as many Omicron cases as opposed to Delta. We expect that the case numbers in Queensland will double every 48 hours or so moving forward. So the rural and remote consumers, I think the most important thing to understand is the protection that we gain from vaccination. So at the moment, it's recommended to have 2 doses of, there's 3 different types of vaccine you can get, and you're recommended to get 2 doses. And then we're also recommended to have a booster dose 5 months after the 2nd dose of the vaccine, unless you're immunocompromised, in which case you should have it sooner. So we know that the vaccines work by helping our bodies to recognize the virus earlier and get rid of the virus before it causes severe disease. So it means that if you're exposed to COVID-19, you're not likely to get as sick. So it's the most important protection we have in terms of preventing severe disease and death from the virus in Queensland.
Thanks, Emily. And you may not be able to answer this question, but we know that we hit 90% across Queensland of people who are eligible to receive the vaccine being double dosed. Mm-hmm. And that has led to bringing forward of some requirements for people to quarantine as being shorter, so not the 14 days, but the 7 days.
Mm-hmm. Yeah.
And we know that sometimes it does take longer than 7 days for the virus to appear. There is that 90% figure for across Queensland, but what does that look like across different rural areas? Is that consistent right across the state?
No, so we know that the vaccination rates in rural and remote areas aren't as high as the vaccination rates in metropolitan areas, which I guess means that the disease severity we'll expect that to be higher in rural and remote areas as compared to metropolitan areas.
Mm-hmm. And the current estimations that our cases are doubling every 2 days is based on also the assumption that everyone who is having symptoms is being tested. And we have heard of some people perhaps choosing not wanting to go into lockdown for Christmas. Is that of concern as well for rural and remote communities if there's lower rates of testing, or in fact challenges to easily be tested and to get those results quickly?
Yeah, that's definitely a concern. And I mean, sometimes people infected with COVID-19 don't even have symptoms. So that makes it even trickier. The most commonly reported symptoms of COVID-19 are malaise. So that's just a feeling of generally being unwell, cough, shortness of breath, fatigue, loss of taste or smell, and then coughing up a lot of phlegm. So anybody who has any of those symptoms, we would encourage to go and get tested. So availability of tests is a concern. The best test we have to detect COVID is PCR testing. There are also a lot of rapid antigen tests available at pharmacies and in supermarkets, but they aren't as accurate as the PCR testing. So they don't have as high a specificity or sensitivity. We would recommend PCR testing, and we need PCR testing especially to confirm the result of a positive rapid antigen test. So it will make it trickier to keep track of how much Omicron or Delta cases there are in rural and remote communities if we're not able to test everybody who meets the criteria for testing.
Thanks, Emily. And Konrad, I'll move on to you to hopefully provide some answers about what individual consumers and communities can be doing to protect themselves, their families and communities in rural and remote Queensland under these circumstances. Could we start first of all with that community level in terms of testing, vaccination levels, and I guess particularly for some rural and remote areas that are welcoming back tourists, but of course tourists who are bringing a little something extra in their luggage, what those communities can do, and then we'll get you to take that on to individuals.
Absolutely. I mean, we know that even looking at somewhere like the Isaac region, just south of where I am, now we know that Emerald today has reported a confirmed case. So central Queensland is obviously going to be on a heightened level. You know, Isaac region themselves, they're still only sitting at 63% fully vaccinated. They're not a big population, but it doesn't take a lot of that unpopulated, unprotected group to really overwhelm those local resources. So the most important thing by far and away that people can do to protect themselves, their family, their community, their hospital, their services is get that vaccination on board. Now, fortunately, as you said, it's actually, I think 90% first dose. I think we're just on 85% fully dosed for Queensland. So by far and away, most Queenslanders have taken the lead and done what they can. But there's still more actually which they can do to provide that protection. And these are the dumb, simple things that everybody thinks are just too obvious to care about. Social distancing still matters. Masks still matter. Hygiene, covering your cough, covering your sneeze, all of those things are still as relevant now as they were back in January 2020 when this messaging all started to come out. Because this is not a computer virus. It's not something which has got an algorithm or it's got intelligence. It is still just a little particle of RNA wrapped in a lipopolysaccharide capsule with some spikes on it. It's not fantastic computer software that's come in from an alien source. It's a simple viral particle that we can easily block from spreading to person with simple measures. Now, the other part of it is that we recognize that everybody is going to get exposed to COVID-19 at some stage. Chief Health Officer and the Health Minister have both acknowledged this in the communications. So how do you then be best prepared for when it comes to you? Well, that is about making sure that you can push yourself as far into that low risk or COVID well category as possible. Have a plan about how you would actually isolate at home, because even though you're vaccinated and well, you still have to stay home for 14 days. So who could help out with checking in on you, bringing kids home from school, getting the food for the cat, bringing the groceries from the supermarket, all of those things that you just do without thinking about it, are you going to need some help with? Do you have your regular medical conditions well controlled? Do you have enough repeats of your tablets to get you through 2 weeks at home? Are you using your puffers properly so that your lung condition is actually as well managed as it could be? And is home actually the right place for you? Because we've got to acknowledge that for a lot of our consumers, home might be a struggle. It might be that they've got multiple generations living under the one roof. It might be that their partner might not actually be somebody who has got a strong enough immune system that they could actually be home there with them. So we have to think about all of these things before it actually becomes a crisis and before that diagnosis actually reaches you, to think, how could I best prepare myself to protect my family and the broader community from this if I inadvertently pick it up from somewhere, from those tourists who absolutely we need. I think that if we told Melburnians and Sydney people that you're going to have yet another year of no Queensland Christmas, we'd see some dreadful outcomes. So we had to be ready for them to come and welcome them and their tourist dollars with open arms.
And it's about them understanding their risks and doing the social public health measures that you've talked about, and we ourselves right across Queensland doing the same. Do you think we've heard of some consumers in rural and remote areas, especially those where it just hasn't appeared yet, that there aren't masks being used and social distancing, all of those measures that you've talked about? How have you been encouraging those in your community, and what advice do you give to people who might feel pressured not to, or even sometimes questioned on what they're doing? It's
leadership. It genuinely comes down to gentle leadership, strong leadership, and then confidence and reassurance. I know that we've got this. There are very few GPs in the local area who have said they will do community management for their GPs. And I was straight away saying, yep, I know that we've actually got a good system. We've got good resources in place. I will more than happily be part of this program. And even out in Tambo, Maureen, even every regional council, every regional hospital has actually got a plan in place about how they can actually help with these services. That that there's been increased funding to the mental health services. So for people who are isolated at home during that time, there will always be somebody there at Lifeline. There are always lots of services available that can help out with that isolation. Our community resources have been stepped up, and that there are going to be Meals on Wheels and all those things who can drop your food at the door. All of the even in the smaller areas, your little grocery stores have got delivery services available, so that yes, you might have to ring up and pay for your order by credit card over the phone, and they might need to drop it off at a time that that you'll be able to collect it. But even our smallest communities know that this is coming, and all of the councils have got plans in place. How do we manage those people who don't think that it applies to them? Look, I agree with the Chief Health Officer that we don't want to be making mandates in Queensland. I think it was terribly sad in Melbourne last year to see so many people end up with criminal records because they were scared. We don't want that in Queensland. But what we do want to have is if everybody is gently showing the right example, if we are all doing the right thing, and then not persecuting those who are struggling, but listening to them, bringing them in and saying, look, if you don't have a mask here, I've got a spare. Would that help you? If you don't know how to use a QR code check-in, can I just take down your details? Rather than making a fight about it, let's try to bring people in so that they're already feeling alienated as enough it is. We don't need to marginalise these people any further.
Mm-hmm. It is really challenging, and I agree. I think it's about respectful conversations and letting everyone know that we want them to be safe and empowered to make the decisions that are right for them, that are going to protect them in the biggest way, as well as the most vulnerable people in their communities and our health system at large. Can I just get you to talk about the public health evidence and where that idea of the vaccine levels, especially when, as there's a comment in the chat that's talking about 90% across the state, but for some 40%, the evidence base, the public health evidence base behind these decisions, when it's very different for rural and remote communities.
It really, really is. And in fact, it seems as though it's paradoxical, because the more we depend on the vaccination and the more trust and faith we put into the vaccination rates as being protective, the more we inevitably see the case numbers burgeon, because we are having people moving around. And so it is totally appropriate that we actually focus on the hospitalisation numbers. And in fact, it's probably most accurate that we talk about the ICU numbers, because we have still got lots of areas where it is appropriate that people are brought into hospital, even if they're not sick, to help prevent from further spread. that's fair enough. And so sometimes those hospitalisation numbers might seem as though they're higher than what they really would be. And we know that even the death numbers that sometimes aren't the best indicator, because some people are in nursing homes, some people are at home, some people sadly were not, were quite frail to start with, and it happens to be that they passed away with COVID. So we can't assume that everybody who gets included in our deaths every day actually wanted or received that full maximum treatment. But certainly our ICU numbers are a good indicator of how well actually are we managing. And we know in Queensland that is still really low. Even though our case numbers are going up and up and up, we are going to get more spread, but they are going to be low acuity people who aren't actually getting sick. They're just going to be doing what they can. And that's what the vaccinations do. Vaccinations will not stop you getting exposed to that SARS coronavirus too. It's only the masks, it's only those other hygiene precautions which will stop you actually getting it. Your vaccination will stop it turning from a little carriage thing up here in the nose to a serious pneumonia illness in the respiratory tract. That's the fundamental difference between vaccination and ICU that we have to remember.
And that messaging is very important. Just because borders are open and we can move around, it's not about being complacent. We're still trying to avoid contracting the disease. It's still about keeping numbers low. It's about keeping ourselves safe and keeping vulnerable people safe. Now I'm going to skip to Emily, and Emily, I'd like to ask you what rural and remote hospitals and multipurpose health centres and primary care centres have been doing during this time to prepare to be ready for if anybody across Queensland presents and it turns out that they were COVID positive.
Yeah. So, I mean, we've had actually quite a long time to prepare because we haven't had COVID-19 in Queensland now for several months. We've been very fortunate, and our previous CHO, Jeanette Young, did a great job. So we're expecting in the MMM 4 to 7 areas that we will be getting COVID cases, and all of the hospitals in those areas have been preparing to be able to assess and manage patients presenting to those facilities who are COVID positive. So it's very contextual how each of those are going to be managed in those particular hospitals. But we, as the epidemic or the pandemic spreads and we get more and more cases of COVID in the community, it's not going to be possible to do what we have been doing, which is admitting everybody who's got COVID, no matter how well or how sick they are with the disease, they all have been admitted to hospital. With the sheer numbers, that's just not going to be possible. So we are going to have to switch to caring for people with COVID at home. But we have to be prepared to manage those patients who are sick or deteriorating in our hospitals, no matter how small. And we also expect that there are some patients who are going to be quite unwell, who will need tertiary care. So they'll need support that can't be given in that rural or remote location, and they will need to be retrieved out to a larger centre. And I suppose that's just like what happens now with people who are significantly unwell with other diseases that exceed the capacity of the rural and remote hospital. They get retrieved out. But the difference is, I guess, that we expect that that might not happen straight away, and that the patient will have to be held in that rural and remote facility pending transfer. I do want to make it, there's a couple of things I want to make clear. So one of them is that really when we're thinking about patients who have COVID or people who've got COVID, there's really three ways we can think about that. So there's the majority of people with COVID who are going to be COVID well. So they're going to have either no or fairly mild symptoms. And that's the majority of people. We think roughly around 60%. And then there's going to be people that have moderate disease or COVID concern. We can call that cohort. So they're people who may have underlying medical conditions or they're just a little bit sicker with COVID. So they're people that may be suitable to be cared for at home, but might need to come to hospital. And there's a lot of factors that go into making that decision. And then finally, there's the COVID sick, the COVID unwell, who've got severe disease. And they will all need to be cared for in hospital and may even need to be cared for in a intensive care unit, which will mean that they'll need to get retrieved out to an intensive care unit. But patients with COVID will present to rural and remote hospitals from any of those cohorts. And patients will present to rural and remote hospitals for care for conditions that have nothing to do with their COVID, but they might have COVID-19. They might break their ankle and need to come in to get that attended to and might have COVID. So rural and remote hospitals understand that and have been preparing for that. It's quite complex and contextual in how that preparation's been happening within each HHS across Queensland. But I guess it's about managing workforce. All of the workforce now is vaccinated against COVID, making sure that we've got the right numbers of PPE. And most rural and remote hospitals don't have a negative pressure room. So we don't have the optimal engineering controls in order to provide support to somebody with COVID-19, but that doesn't mean that we can't. So there are alternatives to the ideal, and again, that depends on the context of each individual hospital, but there's ways that we can isolate patients away from patients who don't have COVID-19, even in smaller facilities, and that we can look at providing treatment options like respiratory support in rural and remote facilities. We've also been looking at screening and triage modelling and communication between the rural and remote hospitals and the larger centres that will be supporting them. Does that answer your question, Melissa?
Thanks, Emily. Yep, that's helpful. And look, I would like to pay special recognition to Maureen in the chat, Maureen and John from Tambo. Maureen, you have not held back through the whole pandemic. You've been letting us know what's been going on, the questions that people in your community have, and it's been incredible for us to be able to amplify your voice, and you've really had an impact during this time. And so we wanted to ask Konrad to talk about what it would look like from someone from your community to receive care if they did have COVID, and how your community and health services would wrap around and support them and others in your community. So, and I acknowledge in the chat what you've shared about how scared people are, uncertain, and that you don't have that visibility of the planning in your local community and how it all links in with your health service and the emergency services. And we really hear you, and my voice is almost hoarse calling on the system and our government to make clear and transparent the plans in place every day. I hope that they will come out, but I truly hope that they will be out in the next 24 hours, along with some incredible co-designed tools, planning tools, checklists, things that people can use to plan and prepare and get ready. So we'll share them as soon as we get them. But Konrad, could I hand over to you?
Absolutely. And look, we continue to be the voice of Tambo, of Windora, of Junda, of Auberthella, of Cooktown, of all of our communities, Doomadgee. We listen to all of you. We love all of you. And what that means is that you have done all of the right things. When you're vaccinated, when you've got your home properly sorted out, when you know where your social supports are, you actually have got just as much right to receive the appropriate level of care as anybody else. You're not going to be displaced just because you live in rural and remote Queensland if you are appropriately low risk. So if somebody does get that diagnosis, it's going to be a confronting situation, because first it'll be a text message, and then it's going to be an interview from either the public health unit or health direct, who are going to be asking some pretty personal questions about your condition, about your symptoms, and about what your situation is like. And if you're unsure about that, please make sure you do talk to the doctor, because it's on the basis of that interview that we can then decide where is the best place for you to receive your care. Now, it might be that actually you tick all of the boxes. You've got no symptoms, you're fully immunised, you've got your other medical conditions under control, you've got good supports, family who are going to check on you twice a day, you've got somebody who can go and walk the dogs and all of those types of things. We might say, yep, you can stay home where you are. We might, however, say, well, do you know what? Your partner is a bit unwell. It's a bit far out of town for you. It might be safest for us to bring you to, let's say, Longreach, where the HHS could actually have an accommodation facility set up where the nurses can come and do a visit, once or twice a day and check in on you. And that's that sort of COVID concern group that Emily was talking about. And it wouldn't be until the people out at Longreach actually say, you know what, this is actually a little bit more than we can handle, that they'd then be talking to Metro North, who would say, yep, we've got a spot for her, bring her on down. And all across Queensland, these mechanisms have been sorted out of what care can be provided to you at home, close to where you live. We want you to be able to stay as close to home as is safely appropriate for you. But that depends on us doing the right things. But have the vaccinations, be honest with the telephone interview when it comes, and being realistic about your symptoms. The people, sadly, we heard about in Sydney who were dying at home were people who weren't actually getting tested, who weren't actually being engaged into the care pathway. Once we know that you've got COVID, we will watch out for you wherever you are in Queensland. Nobody is going to be left alone to just suffer on this in silence. Whether it's your GP checking in with you, whether it's the primary healthcare nurse or your Indigenous health worker, whether it's RFDS or whether it's a phone desk from Metro North, everybody is going to have somebody checking in on how are you going through that 14 days until we know that your disease is over and that you're well again and can re-engage with society. But that all depends on it being a partnership, so that we can keep you safe, we can keep you there. And if that call does come from the HHS of, you know what, I think it might be safest for us to bring you to somewhere else, please don't fight it. We're really trying to make sure that everybody can get through this as safely as possible. So we will be watching out for you. Statewide Rural Clinical Network always has, and we always will be hearing the voices of our smallest communities. You're not alone, Maureen.
And I just want to echo that wherever it's possible, we want to provide care for patients close to home. So we're not going to be shipping people out of their community unless it's necessary for their safety and their well-being.
Thanks, Emily. Thanks, Konrad. And I echo a comment in the chat that thank you, Konrad, for the gentle and beautiful way of explaining scary medical processes. And Emily, thank you for the calmness and the assuredness that you bring to your messaging too. I'm going to ask Suzanne to pop up on the screen a feedback poll about today's session. But while that's happening, the final point that we wanted to talk about is one, again, that I'm almost forced from trying to get a system-wide overview of, which is an assurance that planning has happened at a local level around access to food, medications, community and social support supports mental health services, and that there's business continuity for during a surge. And we are aware of the mechanisms that do that between the HHS and the local disaster management services, but really that transparency across local communities for both health planning and that planning is so important, and is providing a large part of our advice to government at the moment around the importance of them showing that they are taking care of everyone, but supporting local services and local councils to be able to communicate that really clearly to their communities, and to have a mechanism for if you are concerned that that's not the case, that you can access those services, and that the system can swing into place. And that's the community recovery hotline is one way that individuals can access, but then there's also through our organisation and also through 13 Health to raise those concerns and access. So we will wrap up because I can't believe it, we're at time, but thank you so much for taking part today. It's been an incredible year, and we want to continue to do all that we can to amplify your concerns and ensure that you get the care that you need. Thank you, Konrad and Emily, both for your partnerships. I can assure everyone that as gentle and communicated that Konrad is, both Konrad and Emily can be very firm when they need to be when fighting for the needs of rural communities. And thank you for your partnerships, and to all the organisations online who are all calling for the same thing. We'll be sharing our recording and our summary sheet with you all tomorrow. Thank you so much. If you have joined, then you are on our contact list for anything that I may pull together over the Christmas break. So I'm well aware that COVID does not stop for Christmas. So I'll be continuing to be at the table, attend meetings, seek opportunities for rapid consumer consultation and messaging. So you may hear from me. If you're willing to participate, I'm grateful. If you need a break, completely understand. But please continue to reach out via our Facebook page if you have concerns or need to share with us anything around the pandemic and the health response. But thank you all so much. Thank you to my team, tireless team here at Health Consumers Queensland, for doing everything to ensure that we can amplify your voices. And finally, thanks Emily and Konrad. Thanks everyone. Stay safe.
Thank you.
Bye.